On behalf of the American Heart Association, I would like to welcome you to Clinical Perspectives, Foundations of HFpEF, HFmrEF. This event is made possible through the American Heart Association's Implement EF initiative, which is a 3-year initiative supported by Bayer that is designed to improve HFpEF, HFmrEF inpatient care by gaining insights on current unmet clinical needs and practice pathways with a focus on evidence and science-based therapies. We will have a number of educational events throughout the duration of this initiative and encourage you to visit the website at the QR code on the screen to learn more. We have convened a 40-site cohort of multidisciplinary hospital teams seen here. Before we begin, I'd like to quickly review how to use this platform for today's event. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the Zoom webinar helpline. To access live closed captions, please click on the closed caption button found on your screen. Throughout today's presentations, you will have the opportunity to submit text questions for our presenters using the Q&A feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A at the end as time allows. Finally, this webinar will be recorded and available on the Implement EF website within the coming weeks. Today's presenters are Dr. George Shahood and Dr. Pardeep Jund. Dr. George Shahood is Regional Director of the Heart Failure Clinical Program and Director of Cardiology at SSM Health St. Joseph Hospital, Lake St. Louis in Lake St. Louis, Missouri. Dr. Shahood is board certified in internal medicine, cardiology, echocardiography, and nuclear cardiology. Dr. Shahood's particular areas of interest include advanced heart failure, valvular heart disease, and heart disease during pregnancy. Dr. Shahood was a regional lead for Implement HF, a key contributing author to Implement HF publications, and is a member of the Heart Failure System of Care Advisory Group. Dr. Pardeep Jund is Professor of Cardiology and Epidemiology at the University of Glasgow and an honorary consultant cardiologist at Queen Elizabeth University Hospital in Glasgow, UK. His research interests focus on heart failure. He uses clinical trials and epidemiological datasets to understand the epidemiology of cardiovascular disease and test new therapies. Dr. Jund is a member of the Heart Failure System of Care Advisory Group. With that, I will turn it over to you, Dr. Shahood.
Nancy, thank you, and thank you all for joining here today. As Nancy mentioned, we're going to try to go over the foundation for the HFpEF and HFmrEF patient population, especially as we embark on this journey with this new initiative from the AHA, which is the Implement EF. What I will go over today is just trying to lay the foundation for the clinical perspective of this disease entity and how we can make the appropriate diagnosis for those patients. And then Dr. Jund will be following that by talking about the current therapies that are available for our patients with HFpEF and HFmrEF. These are my disclosures. And when we start talking about heart failure, it's important to realize that we have to speak the same language. And this is updated in the recent guidelines, but at the same time, we have a recent universal definition of heart failure, which was published about 4 years ago, which encompasses patients with heart failure irrespective of the ejection fraction. So as we all know, heart failure is a clinical syndrome, and the definition or the basic definition for it is a clinical syndrome with current or prior symptoms or signs of heart failure, which is caused by a structural and or functional cardiac abnormalities, as we see it on echocardiography, invasive coronary angiography, and heart catheterization. But this is corroborated by one of two things: either presence of elevated natriuretic peptides, and here is the cutoff for both hospitalized as well as ambulatory patients, or presence of cardiogenic, pulmonary, or systemic congestion. So simply put, it's having signs and symptoms of heart failure along with either presence of congestion, defined either by echocardiography, chest X-ray, right heart catheterization, or provoked with exercise, or noted elevated natriuretic peptides. And again, this is, as I said, this is irrespective of the ejection fraction. But when we talk about the classification of heart failure, this is when we have to start using the cutoffs for the ejection fraction to better define which patient group we're talking about. And as you can see here, most of our data and clinical trials have focused initially on the heart failure with reduced ejection fraction, which we used to call previously systolic heart failure. And this is defined as an ejection fraction of less than 40% with the presence of signs and symptoms of heart failure, along with either structural or functional abnormality on cardiac testing. And this group of patients with HFrEF constitute about 45% of our patient population. And you can see to the correlate of that, patients with an ejection fraction of more than 40% currently are surpassing the prevalence as well as the incidence of HFrEF, which is getting close to about 55% of our patient population. The previously labeled diastolic heart failure, now we call it heart failure with preserved ejection fraction, as you know, which is defined as an ejection fraction of 50% or above. And this is kind of a unique patient population which encompass multiple phenotypes, as we will touch base on. The HFpEF patient population currently includes about 41% of our patients with heart failure. And then we have that mid-range, what we used to call borderline. Now it's called heart failure with mildly reduced ejection fraction. This is the group of patients with an ejection fraction between 41 to 49%. Unfortunately, till this day and age, till about maybe 5 years ago, we did not have any clinical trials that focus on that group of patients. So we used to lump them with the HFrEF, although their clinical characteristics, as we will see, are more similar to the HFpEF patient population. And then on top of that, you see the HF improved ejection fraction, so heart failure with improved ejection fraction. So these are the patients that used to have heart failure with reduced EF, but with guideline-directed medical therapy, they had an improvement in the ejection fraction by more than 10 points, and with the repeat measurement with an ejection fraction of over 40%. And this is just basically the classification that has been updated recently, that we will need to focus on predominantly these two types, HFmrEF as well as HFpEF. And as you can see here, when you look at the distribution and why it's important to realize that there is a large proportion of patients with mildly reduced ejection fraction, because as we said, this group was largely excluded from prior clinical trials with heart failure. So this is the group of patients with an ejection fraction between 41 to 49%. But it's not a trivial group of patients. It constitutes about 13 to 24% of patients with heart failure. So close to about 1.6 million patients in the US only carry the diagnosis of HFmrEF. And those patients, although they may share the same cardiovascular risk factors, medical history, and prognosis, but they are more likely to have a similar characteristics to patients with preserved ejection fraction, much more than patients with reduced ejection fraction. And why is it important to focus on this group of patients? Again, as I said, it's because one of the major factors is our ability to define this group and our ability to diagnose the appropriate patient and then focus on the current advances in guideline-directed medical therapy becomes quite important. And as I said, till the past 5 or 10 years, we did not have any clinical trials that included these patients. But nowadays, as Dr. Jones will allude to, we have robust pillars for guideline-directed medical therapy for this group of patients. What about the patient with heart failure with preserved ejection fraction, and how can we make the diagnosis? And again, going back to the same definition I alluded to earlier, which is the universal definition for heart failure. It's the clinical syndrome with signs and symptoms which are caused by structural or functional cardiac abnormalities and are corroborated by elevated natriuretic peptide levels or objective evidence of systemic or pulmonary congestion. The prior definition, or the classic definition, is the inability for the heart to pump the blood adequately at normal filling pressures, or the ability to do it on the expense of an elevated filling pressures and elevated left ventricular filling pressures or wedge pressure in the presence of preserved ejection fraction. And how do we make the diagnosis? This is predominantly based on physical exam findings as well as symptoms. So symptoms of dyspnea exertion, orthopnea or PND, and physical findings of elevated jugular venous pressure, lower extremity edema, crackles on the lungs, as well as a third heart sound. And along with that, we have our ancillary testing that will help to seal that diagnosis. So either elevated natriuretic peptides, as we said with the cutoffs mentioned in the first slide, or evidence of pulmonary vascular congestion on a chest X-ray. And nowadays, with advanced imaging, including echocardiography, even at rest, we can see the early signs of diastolic dysfunction with left atrial enlargement, left atrial dysfunction, elevated right ventricular systolic pressure on echocardiography, as well as presence of LV hypertrophy as structural problems identified on routine testing. Cardiac catheterization, we call it the table of truth, because not only we are able to diagnose these patients with preserved ejection fraction by virtue of establishing the diagnosis based on elevated filling pressures, but at the same time, we can go one step further to provoke an increase in the filling pressures in those patients that have an absolutely normal LV wedge pressure. We can do isometric exercise on the cath lab table to provoke the increase in the filling pressures to secure the diagnosis of heart failure with preserved ejection fraction. Because, as we said, it is quite difficult because patients with HFpEF, they have multiple comorbid conditions, including obesity, COPD, sleep apnea. All of these can mimic the same symptoms of heart failure, predominantly dyspnea and exertion. So the presence of shortness of breath by itself is not enough to establish a diagnosis. So we need those corroborative tests. And a lot of times we need to look at invasive hemodynamics with exercise to confirm that diagnosis. So if you look at the epidemiology of heart failure with preserved ejection fraction, we can see that there is an increased prevalence as well as incidence. So this is almost surpassing currently patient with HFrEF. So there is an increase in the incidence of HFpEF over time with equal distribution between men and women. But as we all know, women tends to live longer, and that's when you look longitudinally, the prevalence of HFpEF is higher in women. About 2/3 of patients with HFpEF in the US population are women. But more importantly, when we look at the clinical outcomes, we know that patients with HFpEF have a relatively better prognosis than patients with HFrEF. But the equalizer in this case is hospitalization, which is what we've seen from data with the guidelines heart failure, that patients with HFpEF that had even one single hospitalization, their 5-year mortality rate is up to 75%, which is equal to patients with HFrEF, let alone the morbidity from HFpEF, which is about readmission rate at 30 days, which is about 21%. So to summarize this portion, the prognosis in patients with HFpEF, although it's a bit more favorable, but the moment they have one hospitalization, that will become that an equalizer, that their outcome will be the same as patients with reduced ejection fraction. As you can see here in a paper that was published about 10 years ago now, it showed that the outcome of patients with heart failure at 5 years is identical. This is data from Get With the Guidelines heart failure. that shows that the event rate is exactly the same with 5-year mortality of 75%, irrespective of the ejection fraction. And if you compare that with our general population, you can see that across various age groups, the median survival is greater in our US population compared to patients with heart failure, irrespective of the ejection fraction. And as these patients get older, their survival and mean survival rate goes down, that in those patients in octogenarian and nonagenarian, their survival rate on average is about a year to a year and a half compared to the general population. So we do see almost an equalized event rate and reduced mortality in patients with heart failure, irrespective of the ejection fraction, especially if they had a prior heart failure hospitalization. Now, we all know that the typical phenotype of HFpEF is the obesity phenotype. And this is important to realize that when you look at patients with heart failure, most of the time we see it in older female patients who are morbidly obese. And this is important to recognize that this group of patients, although they are heterogeneous, but we have to realize that this is more kind of a systemic disease, systemic syndrome. It's not just a heart failure per se. We came to realize that this may be part of the cardiometabolic syndrome or kind of a full body failure with an increased rate of inflammation. With these type of patients, we see that this lipotoxicity affect multiple organs, whether we're talking about non-alcoholic fatty liver disease, which promote generalized inflammatory changes, whether you look at the visceral adiposity, which is by itself is a significant marker of inflammation, which can increase insulin resistance and at the same time reduces outcome in those patients. And not to forget the effect of the perinephric fat deposition, which can affect the glomerular function. And lastly, but not leastly, the effect on the lungs as well as the skeletal muscles cannot be emphasized, because these deposition of fats, even around the lungs, can cause more of a restrictive lung disease, reduces the vital capacity, and worsen the symptoms of dyspnea. And at the end, skeletal muscles don't perform adequately as in normal patients. There's an increased adipose tissue infiltration in the skeletal muscles, which will alter the signaling, especially insulin signaling, which can increase the generalized fatigue and tiredness and lack of stamina in those patients. All of these effects can worsen patients' symptoms, reduce exercise capacity, as well as worsen their quality of life. I did mention earlier the important role of checking the natriuretic peptide to confirm the diagnosis of heart failure. But in patients, the presence of a normal NT-proBNP does not exclude the diagnosis, because as you can see on the left side of the screen, about 40% of the patients with HFpEF, they have relatively normal NT-proBNP of less than 125. And close to about 2/3 of these patients have an NT-proBNP of less than 220. So the absence or the normal NT-proBNP levels does not exclude the diagnosis of HFpEF. And I'll show you why we may have these patients with normal NT-proBNP despite being quite symptomatic. But having said that, if you look at the right side of the screen, this graph shows clearly that the elevated natriuretic peptides, as we all know, is a poor prognostic marker. And patients that have elevated NT-proBNP have a worse prognosis and reduced event-free survival compared to those patients with a HFpEF but relatively low or negative NT-proBNP levels in the green graph. And part of the reason for that is what we label as the BNP deficiency in HFpEF patients. And there are several potential causative reasons for why we have a lack of BNP release in patients with HFpEF. Part of it is related to genetics. Part of it is related to obesity because we know that NT-proBNP correlates inversely with the body mass index. And also could be related to the lack of wall stress because in HFpEF patients, we have relatively smaller cavity size and increased wall thickness. And we know that the wall thickness correlates inversely with the BNP levels. So that's why we see lack of BNP elevation in HFpEF patients compared to HFrEF patients. So almost about 1/3 of patients with HFpEF, they have relatively normal NT-proBNP levels despite noted elevated fitting pressures on invasive hemodynamics. And this BNP deficiency can promote increase in the blood pressure as well as fluid retention and adiposity in those patients with HFpEF. And that translates into worse outcome, even though the NT-proBNP level is low. So patients with HFpEF may not live with an elevated NT-proBNP, but that's part of the reason it becomes a challenge when patients present to the hospital with progressive shortness of breath, lower extremity edema, chest x-ray may be clear. You check the BNP and it's normal. Then you are having this dilemma. Does the patient truly have a HFpEF or not? And that's why we have to look at other diagnostic markers, whether it's with use of echocardiography or even with use of invasive hemodynamics. So by echocardiography, we can look at what we label as E to E prime ratio, which is the ratio of the early filling through the mitral valve, which is the E, over the E prime, which is the tissue velocity in the myocardium. And this ratio seems to correlate quite well with invasive measures of elevated fitting pressures, which is the wedge pressure. So you can see nice correlation between the E to E prime compared to wedge pressure. But having said that, it's important to realize that the E to E prime ratio only is important if it is elevated of more than 15. Because if your E to E prime ratio is less than 15, there is quite a significant crossover between the patient population and the NCD, which is non-cardiac dyspnea. And this is an important paper that was published in 2017 by the Mayo Group led by Barry Borlaug that shows that some of these echo markers are important, but it may not be enough to make the diagnosis. And we may need to go to the next step, which is invasive hemodynamic assessment in those patients that we are still don't have a certain diagnosis of HFpEF. So you do a cardiopulmonary stress test, and if this still does not confirm the diagnosis, the second step is to go with exercise hemodynamics to confirm the presence of elevated LV fitting pressures with exercise. But not every patient needs to go to the cath lab to confirm the diagnosis. So there is a good scoring system that also came out of the Mayo Group, which is the H2 HFpEF score, which will help you to increase or to confirm the diagnosis of HFpEF or give you at least an idea about the probability of HFpEF. And this includes 5 variables. 2 of them are echo variables and the other 3 are clinical. And as you can see, you have points for each of these variables. So you get 3 points in patient with AFib, 2 points in patients who are obese, so BMI more than 30, and then 1 point for the other factors, which is hypertension, pulmonary hypertension, age of more than 60, and then increased fitting pressures by echo Doppler with an E to E prime more than 9. And if you can look at these scores, your sum up score can help you to get the probability of HFpEF. So if you have a score of 0 to 2, this is unlikely to be HFpEF. But you have a score of 5 to 9, this is very likely to be HFpEF with over 80 to 90% probability of securing the diagnosis. Those patients with a score between 2 to 4, this is the group of patients that we may need to use invasive hemodynamics and exercise testing to confirm the diagnosis of HFpEF. And there is more recently a robust data to use only 3 out of these variables, which showed a high correlation. And these 3 variables are age over 60, an increased body mass index of more than 30, and a history of atrial fibrillation, which not only showed a high probability for the diagnosis of HFpEF, but also worse outcome. So if you have a high probability of more than 75%, these patients usually have worse outcome with reduced 5 to 10-year mortality. And we touched base earlier about the phenotypes of HFpEF, and in reality, it may be just a natural temporal progression of disease, where in the early stages, these patients with HFpEF may have minor abnormalities, which is potentially an LV hypertrophy, reduced LV relaxation and compliance, and early reduction in longitudinal function with the strain imaging. The patients will progress from there into the middle stage, where you have more reduction in the left atrial compliance, increased left atrial size, and potentially atrial functional mitral regurgitation. And in those cases, patients may start having elevated fitting pressures even at rest in the mid-range. And as you progress to the right side, this is your phenotype where you have a dilated right ventricle, presence of pulmonary hypertension, increased tricuspid regurgitation, and reduced RV contractility as well. These are usually the patients that have worse prognosis on the long run, and we have to be mindful when we establish the diagnosis to start managing those patients early before they progress in their disease state. And not to elaborate much on the phenotypes, but most commonly those patients have the obese cardiometabolic phenotype. Less so we see the ischemic patient population. And the other two types is those patients with arterial stiffness and hypertension, patient with pulmonary vascular disease and HFpEF, and lastly, the LA myopathy HFpEF patient population. These are the patients that you will start noticing enlargement of the left atrium, and eventually they will have the phenotype 3, which is progression into pulmonary hypertension, as well as right-sided failure with worsening tricuspid regurgitation. Lastly, I will just give you kind of a broad overview of the key points for the treatment of HFrEF, which Dr. Jund will be talking about in more details. But just to highlight one point, that the first and foremost important factor is to get the right diagnosis for both HFpEF and HFmrEF, and rule out any alternative etiologies that can masquerade heart failure with preserved ejection fraction, as we said, potentially overweight and obesity, COPD, and so on and so forth. A lot of these patients will need to be initiated on the appropriate pillars of GDMT that Dr. Jund will talk about, specifically talking about the SGLT2 inhibitors, and as well diuretics in those patients that are volume overloaded. And then we have to look at these phenotypes and address these potential underlying comorbid conditions: hypertension, iron deficiency, diabetes, CAD, atrial fibrillation as a major comorbid condition, before you go down the path of disease-specific guideline-directed medical therapy, or the important pillars of GDMT that I will go ahead and let Dr. Jund touch base on that. So we'll go ahead and move forward to the next section of this presentation, and I will lead the way for Pradeep to take it over from here.
Thank you, Dr. Shahood. Just a reminder to our audience, please don't forget to submit your questions using the Q&A feature on your control panel. Next up, we have Dr. Jund. The floor is yours.
Thank you very much, Jennifer. Thank you very much, George, for an excellent overview of heart failure with mildly reduced and preserved ejection fraction. And my job this afternoon is to give an overview of the evidence base for the therapies and treatments for these patients, and really why we're all here as part of Implement EF to try and improve the treatment of our patients. These are my disclosures. I've been involved in a number of these trials. So here are the current guidelines for the management of heart failure with mildly reduced and preserved ejection fraction from the AHA, along with the other major bodies, the ACC and the Heart Failure Society of America. And as you can see, the group heart failure with mildly reduced ejection fraction and preserved ejection fraction slightly differently. That's on the basis of the evidence, but I'm going to go through this step by step as we go. So what I would like to do first of all is go back to this group of drugs that George mentioned earlier, the SGLT2 inhibitors, because when these guidelines were written, we really had one trial, the EMPEROR-Preserved trial. This was a positive trial with empagliflozin in patients with mildly reduced and preserved ejection fraction heart failure, showing that we could reduce the primary composite of cardiovascular death and heart failure hospitalization. And this is mainly driven by heart failure hospitalization, as you can see here, but it was certainly a very positive trial, and that's what the guideline writers had when they wrote the guidelines in 2022. That's why it got a 2A recommendation, but just shortly around the time the guidelines actually came out, we also published the DELIVER trial with dapagliflozin in the same patient population, patients with and without type 2 diabetes with mildly reduced or preserved ejection fraction heart failure, and found an almost identical result. And therefore, now really we have two large randomized controlled trials in mildly reduced and preserved ejection fraction heart failure to add to those trials that we already have in reduced ejection fraction heart failure. And if we look at the totality of evidence here, you can see all of the trials put together. And I think you would agree that if you look at the reduction in cardiovascular death and heart failure hospitalizations with SGLT2 inhibitors, is pretty consistent across the entire spectrum of patients with heart failure. And that's why I think they've really become the first pillar of the treatment of HFpEF, because of this overwhelming evidence from two large randomized trials. So we've really moved to an era where, having for a very long time had no therapies for these patients, we now start to have some pillars of therapy. But let's look at the other parts of the guideline and what else is there. Well, we have a 2B recommendation for ACE inhibitors and ARBs for mildly reduced ejection fraction heart failure, and that's on the basis of some analyses I'll show you in a minute. But we also have angiotensin receptor neprilysin inhibitors as a 2B recommendation for treatment with HFpEF. Now, why is that? Well, let's look at the evidence. This was the trial of an angiotensin receptor neprilysin inhibitor, sacubitril/valsartan, in patients with preserved ejection fraction heart failure, the PARAGON-HF trial, again published around the time of EMPEROR-Preserved. So here was the results, the primary results of PARAGON-HF. You can see here that there was a reduction in the patients randomized to sacubitril/valsartan, but it did not reach statistical significance. You can see that the rate ratio, 95% confidence interval, crosses 1, and the p-value is just above what we conventionally use to indicate statistical significance of p equal to 0.06. So it just missed the mark. And when a deeper dive was done into the trial and looking at the subgroups, one subgroup showed that there was a significant difference between those patients. The patients who had a lower ejection fraction below the median, so that was 57%, they appeared to derive some benefit, and those with an ejection fraction above this didn't really appear to derive benefit from sacubitril/valsartan. And the reason that we thought this subgroup was a true finding was that it persisted even after we adjusted for the differences in those different patient populations. So once you adjusted for differences in age, sex, race, where the patients came from in the region of the world, that evidence that the patients with a lower ejection fraction did better in sacubitril/valsartan persisted. And if you look at this slide here, you can see along the bottom of the slide, the x-axis is ejection fraction. The solid black line is the treatment effect, and the dotted line is the confidence interval. So above 1 is in favor of valsartan, below 1 is in favor of sacubitril/valsartan. And you can see here that once we start getting above what is called a normal ejection fraction, so around 55 to 60%, we start losing the benefit of sacubitril/valsartan, in keeping with what I just showed you. So the FDA and the guideline writers took that to really mean that in patients with a below normal ejection fraction, that includes some of our patients with mildly reduced and preserved ejection fraction heart failure, that these patients may derive benefit from sacubitril/valsartan, and that's why it is in our guidelines. Now, what about an angiotensin receptor blocker? Well, we saw a very similar response according to ejection fraction with the angiotensin receptor blocker candesartan in the CHARM program. So again, it all seems to all fit. These RAS blockers seem to do better in patients with an ejection fraction below normal, so 55 to 60, than in the patients who have a high ejection fraction. And actually, there's pathophysiological reasons why that might be, because you get less renin-angiotensin and neurohumoral activation at high ejection fraction. So if you've got less neurohumoral activation, you might think there'll be less benefit from neurohumoral blockade with RAS blockers. But that brings us on to another RAS blocker, the mineralocorticoid receptor antagonists, so MRAs. And for a long time, we've really only had spironolactone as our MRA that we can use in our patients with heart failure, or that have been tested in mildly reduced and preserved ejection fraction heart failure. For reduced ejection fraction heart failure, we have spironolactone and eplerenone that have been tested. But in this patient population, we only had a trial that looked at preserved ejection fraction heart failure. And whilst we have a 1A recommendation in reduced ejection fraction heart failure, we have this 2B BR recommendation for MRAs and HFpEF on the basis of this trial, the TOPCAT trial. And the TOPCAT trial was conducted in the Americas, in North America and South America, USA, Canada, Argentina, and Brazil, and also in Russia and Georgia. And the trial, as you can see here on the left-hand side of the slide, as you look at it, you can see the trial again missed statistical significance, but when they dissected down the trial, they noticed something rather strange. They noticed that there was a treatment effect in the Americas, but not in Russia and Republic of Georgia. And you can see here that the event rates on the right-hand side are very much lower than the event rates in the Americas, maybe suggesting, as we heard from Dr. Shahood, these patients had high event rates. They're very likely to have hospitalizations and die. And given this very low event rate observed in the TOPCAT trial in those patients, there was some concern that these patients actually didn't have HFpEF and were not taking the medication. And indeed, in further dissection of the trial, in these analyses that have been published, these patients didn't even seem to be taking the drug because there was no evidence of the byproduct of breakdown of spironolactone cananone in the blood in many of the patients who were in Russia who were said to be taking the drug. You can see here, and they had no change in the creatinine, and as we know, creatinine changes often when we start an MRA. So that's why, given these uncertainties about the trial, it was given this 2B BR recommendation by the guidelines, and really focusing in on this issue around the Americas and Russia and Georgia. So that's where we were for a long time. And then just last year, we were fortunate enough to publish this trial, the Fine Arts trial, with a new type of MRA, a non-steroidal MRA, phenerenone. And in this trial, we randomized patients with mildly reduced or preserved ejection fraction heart failure to phenerenone or placebo, and a target dose of 20 milligrams if their eGFR was less than 60, and 40 milligrams if their eGFR was over 60. And here, now that we had a larger trial without the issues of Russia and Georgia that plagued TOPCAT, we were able to demonstrate a benefit of phenerenone in terms of reducing morbidity and mortality, so cardiovascular death, heart failure, hospitalization in these patients with mildly reduced and preserved ejection fraction heart failure. When we look at this and break it down, this was really driven by heart failure events, so heart failure hospitalizations, urgent heart failure visits, so that's emergency department visits or outpatient clinic visits where a patient had to receive intravenous diuretics. But again, it's very clear and very consistent with TOPCAT, and although we did not see a reduction in cardiovascular death, certainly numerically there were less deaths in this phenerenone group compared to the placebo group. Actually, that's not surprising. You may be surprised that we didn't see a reduction in cardiovascular death, but that's often the case with mildly reduced and preserved ejection fraction trials. We don't see a reduction in cardiovascular death because the patients with mildly reduced and preserved ejection fraction have a slightly lower event rate in terms of cardiovascular death and have less cardiovascular deaths compared to non-cardiovascular deaths than the patient with reduced ejection fraction. Therefore, it's slightly harder to show a reduction in CV death. You need to either do a twice as long trial or twice as big trial. But what about the subgroups in fine arts? So we'd seen that there were some issues with the subgroups in Paragon, and there were some reasons behind that. And we also saw some issues, of course, with the subgroup according to region in the TopCat trial. But here in the fine arts trial, we saw no evidence of any difference according to any of the subgroups that we pre-specified in the analysis. So the treatment effect was consistent, and we've since then also published some data on left ventricular ejection fraction, again showing that there's no reduction in the benefit at the higher end of the ejection fraction scale. So again, I think this helps us, it gives us another drug to use, another pillar of heart failure with preserved ejection fraction, mildly reduced ejection fraction therapies. I want to briefly touch on safety and tolerability of finerenone in the fine arts trial. It was pretty much as you might expect from an MRA. There was more hyperkalemia with the patients on finerenone than there was in the patients on placebo, but interestingly, importantly, less hypokalemia, so low potassium. And we know that many of these patients suffer from hypokalemia, have to have potassium supplements added to their therapy. So actually this is another reason why MRAs I think are very useful in our patient population. So what do we do about MRAs? We put it all together. I showed you the meta-analysis of the SGLT2 inhibitors in heart failure. Now if we put the preserved ejection fraction trials together with the reduced ejection fraction trials for MRAs, you can see a very consistent benefit for reduced ejection fraction. That's the RALS and Emphasis HF trials. And here slightly less consistent for TopCat versus fine arts. But when you look at it all together, you see a benefit overall in the mildly reduced and preserved ejection fraction heart failure trials, but less of a bigger benefit in the reduced ejection fraction trials. And that's probably because these trials in reduced ejection fraction were done in a different time and in a different risk population, unlike the SGLT2 inhibitor trials, which were all done very in a similar time period in 2014 to about 2019. These trials were done over very many years, almost 20 years. So things changed a lot between those times. So here we have the treatment of HFmrEF and HFpEF as of today, as of our current guidelines of 2022. Of course, they're showing you now that there's probably some more evidence that probably improves the quality of evidence for SGLT2 inhibitors, and I would not be surprised if we see that upgraded in the next set of guidelines. I've shown you the data for ARNIs, ACE and ARBs, which I think will stay the same, and also the new evidence for MRAs, which again, I think will be interesting to see how the guidelines interpret that. But to me, personally, I think it strengthens the place of MRAs in the treatment of heart failure with mildly reduced and preserved ejection fraction. So in summary, I think we now have multiple therapies that improve outcomes for our patients. The SGLT2 inhibitors are definitely a pillar, as we call them. And MRAs tend to be effective across the ejection fraction spectrum as well as ARNIs in those with a lower than normal ejection fraction, and beta blockers in MREF and ARBs in HFpEF. Now, all of these data are lovely, they're fantastic, but the reason why we're all here is because we know that our patients don't get these therapies, and they're only really valuable if we take them out of the clinical trials and start using them to treat our patients, and that's the journey that we're all going to embark on together. So with that, I'm going to finish. I'm looking forward to participating in the question and answer session.
Thank you, Dr. June and Dr. Shahood. We'll spend the rest of our webinar addressing some of the questions we've received. If we're not able to address your question during the webinar, please don't hesitate to email the initiative at implement.ef@heart.org. And just a reminder, you can submit questions using the Q&A feature in the control panel.
Dr. Jund, we did have a follow-up question for you. The patients in Georgia and Russia were not on the MRAs, or the MRAs didn't play a factor because they had HFpEF?
Yeah, that's a great question. I think it's probably two things. So if you look at some of those references that I put up earlier, the TopCat team did a fantastic job of showing that many of these patients probably were not actually taking their MRA. So they couldn't detect any evidence in their blood samples that they took that they had been taking it. They didn't see any of the byproduct canrenone in their blood when they should have had it because they were randomized to an MRA. And then, as I also showed you, their event rate was also much, much lower than the patients in the Americas. And that does make us worry that actually they might not have had HFpEF, because as Dr. Shahood said, we know that patients with HFpEF are at high risk of events. So if you have a bunch of people who are not having events, you have to question whether or not they actually had the disease, because they didn't behave as if they had the disease. So actually, it's probably those two factors. They weren't taking the drug, and maybe they didn't have HFpEF in the first place to start with, which is why we had that uncertainty in the guidelines. And I hope now that with the evidence we have from the Fine Arts trial, we now have good evidence that MRAs are beneficial for this patient population.
Thank you, Dr. Jund. Dr. Shahood, we have a question for you. When should palliative care be integrated in HFmrEF management?
A very important and tricky question, because it all depends on the on a couple of factors. Again, most patients with HFmrEF, their prognosis, although we said that it's better to some extent, but the moment they have any hospitalization, it's going to be as bad as patients with HFrEF. We usually look at these patients after they come into the hospital for the first time to try to look at multiple things. Number one, what are their goals of care? Number two, how old are they, and do they have any other comorbidities? Are we able to improve their outcome with guideline-directed medical therapy, with certain device therapies? Are they potentially candidates for advanced heart failure therapies? And it also depends on the underlying pathophysiology. We do involve our palliative care team relatively early in the disease process, because most of these patients, they have not had these discussions happen before. They don't know what to do in case they have a recurrent hospitalization. They don't have any advanced directive or any discussion about the goals of care. So we do involve them relatively early on, even after the first hospitalization, but for sure after any recurrent hospitalization. The final decision will also depend, again, on whether we feel that there is something that we can do to improve their outcome. And if we're basically locked in a case where they're either maximized or cannot tolerate any of their GDMT, they're not sick enough to require advanced heart failure therapies, or they are not candidates for advanced heart failure therapies, we'll have to start talking about the goals of care and what should we look next in those patients. So I would say this is one of the areas that is still evolving, especially as it pertains to the HFmrEF patient population, because we have not taken care of these patients as we should over the years. We have more robust data with the use and the success of palliative care in patients with HFrEF in general. HFpEF patient population, a lot of them, and again, it's the true HFpEF. We're trying to kind of distinguish between the masquerades or the other different phenotypes of HFpEF, like, for example, cardiac amyloidosis, cardiac sarcoidosis, or any of these other phenotypes that have the specific treatments. But purely heart failure with preserved ejection fraction is a very well-known disease entity at this day and age. The use of palliative care in those patients will basically depend on where they are in the trajectory of their disease and what's their outlook on the long run.
Thank you. We have another question. Do you recommend for HFpEF patients to undergo a sleep study to rule out sleep apnea?
I would say always the answer is yes. So one thing that we did not touch base on earlier is that patient population, they have a higher rate of comorbid conditions, much more than HFrEF. Secondly, HFpEF patients, only 50% of them die because of heart failure. The other 50% die because of comorbid conditions. And when we look at these comorbid conditions, for each additional comorbid condition, their mortality can go up by about 20%. So that's why it's important to realize that other comorbid condition, whether it's sleep apnea, whether it's chronic kidney disease, whether it's iron deficiency anemia, whether it's COPD, those can impact the outcome of those patients. So I would say we always do screen patients with HFpEF, especially obesity, a phenotype of HFpEF, because treating sleep apnea will be important to modify their disease process. It might improve as well to prevent or at least stabilize any progression of pulmonary hypertension in those patients. And we know that one of the markers of worse outcome in patients with HFpEF is elevated PA pressure. So patients with pulmonary hypertension do have a worse prognosis, and those are the ones that eventually will develop right-sided failure, significant tricuspid regurg that will impact their outcome. So simply put, if we encounter patient with HFpEF, we have to make sure that we screen for any and all of these comorbid conditions, predominantly sleep apnea. And I would say also we sometimes miss on screening patient with iron deficiency anemia because their quality of life will be impacted as well in this group of patients.
Thank you. Another question is, how strong is the literature for the ARNI and the MRA for HFmrEF and HFpEF? Do you think it will move up to 1A or 2A for both?
Who's that
So
for? Would you like
that's why for you, Pradeep. Go ahead.
It's a tricky question because we're not the guideline writers and we can only sort of guess at what they might say. If I was to guess, I would say I suspect the ARNI recommendation won't change. We don't have any new data. The MRA recommendation, I suspect, will change because we have a new trial, which was positive. And how the guideline writers interpret that, I don't know how they'll interpret that. Will they give a separate recommendation for finerenone because it's a non-steroidal MRA, or will they lump it in with spironolactone because it's an MRA? I don't really know. But what we do know is that we have a guideline recommendation for MRAs at the moment for spironolactone, and I'm sure we'll get one for finerenone. And I think that both of these drugs probably work in our patients with mildly reduced and preserved ejection fraction heart failure. And what we're hoping to do and see over the course of Implement EF is an improvement in the usage of these drugs for our patients. And I know many people have asked some other questions in the chat as well, or the Q&A about what will happen to certain drugs and GLP-1 receptor agonists as well. Again, it will be interesting to see how the guidelines look at these sorts of drugs as well, but currently they're not in the guidelines.
Yeah, and I agree with Pradeep. I mean, this is quite important because the data is the data, and this is what the guideline writers use to make those recommendations. And with the fact that the Paragon HF, although missed its primary endpoint, but the subgroup analyses in these patients that are women or with an ejection fraction below normal did derive the benefit. That's part of the reason now why it was included in the guidelines, but it still was given a class 2B recommendations. There is not other new data to support an escalation of that class. But for the MRA, it will be interesting to see, as Pradeep mentioned, if they will lump it as one class versus two classes, because the FDA clearly includes finerenone as its own group of non-steroidal MRAs. And this is the one that has the benefit, and it was a positive, strongly positive trial compared to the TopCat, which the primary outcome was not met. But again, if you do look at the data in the Americas, it was positive. The interesting fact, which is why we're kind of interesting to see the practice patterns, is the use of MRAs, steroidal MRAs versus non-steroidal MRAs based on the data. And I see one question in the chat because of the pre-authorizations as well as potential cost with the use of finerenone compared to a cheaper spironolactone. Does it carry the same benefit? For us, it's hard to say. That's why we're tracking both utilization of the steroidal and non-steroidal MRAs to see the practice patterns. Personally speaking, if we are able to get pre-authorizations for the finerenone based on the appropriate indication in this group of patients, that's what I usually go with. Having said that, I have a lot of patients that are on steroidal MRAs with spironolactone or eplerenone that have been on it for a while. So we don't make these recommendations. The beauty of this quality initiative is at least to establish a foundation of where we are currently and how can we make sure that we improve the implementation of the current guideline recommended medical therapies. The pillars of GDMT for HFpEF may change, as Pradeep mentioned. It may be 3 pillars between the SGLT2 or SGLT inhibitors, the non-steroidal MRAs, and potentially the GLP-1 receptor agonists. That may be the new foundation for GDMT for the HFpEF patient population. But as it stands now, Pradeep highlight nicely the classes of medications, the evidence behind it, and what the guideline says, and that's what we go with. The registries that we are conducting will help us to see what we are doing currently for managing those patients, because we know that we are still below the recommendations in utilizing any of these guideline-directed medical therapies. So whether you end up using a non-steroidal MRA, which is highly recommended, or steroidal MRAs, you do whatever is best for your patient. And we're here basically just to kind of look at how the transformation is going to happen with more adoption of guideline-directed medical therapy for these patients.
Thank you so much, Dr. Shahood and Dr. June. This concludes our Clinical Perspectives, Foundations of HFpEF and HFmrEF webinar. Thank you very much for attending today's webinar. You will receive a post-event survey with some questions to help us as we continue to develop future educational opportunities, and would greatly appreciate it if you take the time to complete. This event was presented as part of our Implement EF initiative, supported by Bayer. We are hosting a follow-up Healthcare Professional Connection Forum on Wednesday, December 10th from 10 a.m. Central to 1:30 p.m. Central. This half-day forum will bring together innovative models and practices to improve identification, diagnosis, and treatment of HFpEF and HFmrEF care. Registration for this event is free and is now live. You can register by scanning the QR code on the screen or click on the link in the chat. Thank you for attending today's webinar. Should you have any questions or feedback, please feel free to email us at implement.ef@heart.org. We hope to see you at the virtual forum in December. This concludes today's webinar. Thank you.